Family planning is, it's considered one of the top 10 public health achievements of the 20th century. I mean, it completely changed society.
Oh, absolutely. It fundamentally altered modern medicine.
Right. Yet, despite a centuries, all these medical advancements, there is this staggering statistic in the source material today. Nearly half of all pregnancies in the U.S., around 43 to 45%, are still unplanned.
Yeah, it really is a phenomenal gap between medical innovation and, human reality. We have these
Yeah.
highly advanced tools available.
But the numbers tell a totally different story,
Exactly. A story of widespread systemic and, frankly, behavioral disconnect.
which is wild.
Yeah.
Because usually when we talk about a medical diagnosis or a treatment, there's this expectation of absolute precision. You break your arm, the x-ray shows that jagged white line, and the doctor just points and says, there it is, broken.
Right. Medicine loves a binary. We like things to be perfectly categorized, broken or not broken.
It's visible, it's clean, and it's incredibly comforting. But then you step into the world of reproductive health, and suddenly that x-ray machine is basically useless
Completely useless. You're dealing with an incredibly murky landscape.
because you're taking complex human biology and mixing it with the most unpredictable variable on the planet, which is human behavior. So welcome to today's deep dive.
Glad to be here for this one.
Our mission today is to navigate this really complex, rapidly evolving landscape of contraception and reproductive care based on our source textbook. And for you, the learner listening right now, sifting through all this medical jargon to find what actually matters for your own personal health or just to be a genuinely well-informed human being, it can feel totally overwhelming.
Oh, it's a lot to process. The terminology alone is a barrier.
Yeah. So we're going to cut through that noise. We're not just going to list off what these methods are. We're going to look at the fascinating biology of how they actually work and the surprising real-world variables that cause them to fail.
Okay, let's unpack this, because before we evaluate specific devices or, pills, we have to understand how the medical field even defines success in this arena.
Right. What does success even look like?
Well, major national public health initiatives like Healthy People 2030 have set a clear goal. They want to decrease the percentage of unintended pregnancies from that 43% down to 36.5%.
Which is a huge drop when you're talking about millions of people.
It is, but the metrics used to measure the tools to get us there rely on a crucial, often misunderstood distinction. We really have to separate theoretic effectiveness from typical effectiveness.
Okay, so I always think of theoretic effectiveness like testing a brand new car's fuel efficiency on a closed, perfectly flat track.
With a professional driver.
Exactly. The conditions are pristine. Typical effectiveness is taking that exact same car and driving it in bumper-to-bumper city traffic. You're late for work, you're spilling coffee on yourself, and you totally forgot to check the tire pressure.
That is the perfect analogy. Because human error is the single biggest variable in medicine. Theoretic effectiveness assumes perfect, absolute, unwavering compliance from the patient.
Which basically never happens.
Right. Typical effectiveness measures what actually happens when living, breathing, distracted humans take that method home. And bridging the gap between the test track and the city traffic is where actual clinical care happens.
So how do providers actually bridge that gap?
Healthcare providers use a foundational tool for this, known as the braided mnemonic.
Braided. Okay, let's break that down because at first glance, a 7-letter acronym sounds like a lot of bureaucratic medical red tape.
I know it sounds like that, but it functions as the exact opposite. It's really a comprehensive framework for informed consent. So braided stands for benefits, risks, alternatives, inquiries, decisions, explanations, and documentation.
Wow. Okay. That covers a lot of ground.
It has to. When a provider sits down with a patient, they aren't just handing over a prescription pad. They have to walk through the benefits and the risks. They have to offer alternatives.
And the inquiries part.
That is crucial. They must invite inquiries, allowing the patient to ask how this specific method fits into their unique lifestyle. They support the patient's decisions, provide clear explanations of the mechanics, and handle the documentation.
So if a patient doesn't fully grasp the explanations of how a medication biologically interacts with their body, or they aren't given the space for inquiries to admit, hey, I work night shifts and I can't take a pill at the exact same time every day,
then that method is going to fail.
yeah, that theoretic car is practically guaranteed to crash in typical traffic.
Exactly. The clinical outcome relies entirely on the patient being empowered with comprehensive knowledge. Without that, typical effectiveness just plummets.
Since human behavior is the main driver of that effectiveness gap, Let's look at the methods that rely almost entirely on the user's daily actions. I'm talking about fertility awareness-based methods, or FAB methods, and physical barriers.
FAB methods require immense daily dedication, and as a result, they carry a typical failure rate of about 15% during the first year of use.
15% is pretty high.
It is. Historically, these involved methods like the calendar method or standard days. People would use physical tools like cycle beads.
Cycle beads,
Yeah.
like an actual necklace?
Basically, it's literally a color-coded string of beads where you move a little rubber ring every single day to track where you are in your cycle.
Wow. But the source material shows it goes so much deeper than just counting days on a calendar. It gets deeply physically biological.
Yeah.
Users track their basal body temperature, or BBT.
Right, which means taking your temperature every single morning before you even sit up in bed or speak. You're looking for the tiny spike that indicates ovulation has occurred.
And then there's the tracking of cervical mucus.
Yeah.
Looking for a very specific consistency. The textbook calls it Spinnbarkeit.
Spinnbarkeit, yes, it's a German term.
Okay, what exactly is that? Because that sounds incredibly specific.
It is. It refers to the highly stretchable, egg-white consistency of cervical mucus that signals peak fertility.
Egg white consistency.
Yes. The biology behind this is actually quite elegant. As ovulation approaches, estrogen levels peak, causing the cervical mucus to change dramatically. It becomes thinner, clearer, and can literally stretch about 5 centimeters between your fingers.
5 centimeters, that's quite a bit.
Right. And this specific consistency creates microscopic channels that physically facilitate the survival and upward motility of sperm.
So it's basically creating a highway.
A very hospitable highway, because without this specific mucus, the vaginal environment is naturally acidic and hostile to sperm, making conception highly unlikely.
What blows my mind is how we've taken these deeply ancient analog biological signals like feeling the stretch of mucus or reading a mercury thermometer and merged them with modern technology.
Well, the tech boom in this space is massive.
Yeah, we've moved from strings of colored beads to FDA-cleared Bluetooth wearables. We have the AVA bracelet tracking physiological stress, the Wink thermometer syncing instantly to your phone,
Right.
and the Yono device that you wear in your ear overnight to continuously monitor basal temperature.
It's incredible. And all of this is feeding millions of deeply intimate data points into algorithms on apps like DOT or Natural Cycles.
Which we are definitely going to circle back to later because that raises some huge questions.
Yeah.
But essentially, we are turning biological markers into massive digital data sets.
Yes. The goal is to predict ovulation windows with machine learning accuracy. They're ultimately trying to lower that 15% failure rate by just removing the user's manual calculation errors from the equation.
But even with all that technology predicting your fertile window, you still need a barrier method if you're going to be active during that time. Which brings us to condoms.
The classic barrier method.
Right. Male condoms have a 13% typical failure rate, and female condoms sit around 21%. But wait, I need to stop you there and push back on something from the text regarding condom materials.
Sure. What stood out to you?
Usually when we hear the words natural or lambskin in the health and wellness space, it is heavily marketed as the premium, safer, cleaner option.
Are you telling me the natural option is actually the most dangerous when it comes to viruses?
Biologically speaking, yes. Natural skin condoms are made from lamb cecum.
Which is part of the intestine, right?
Exactly, part of the animal's intestine. Because it is actual biological tissue, it transmits body heat much more effectively than synthetic materials. This creates a different sensation that some users strongly prefer.
Okay, I get that. But where is the danger?
Well, because it is an animal membrane, it naturally contains microscopic pores. Now, those pores are just small enough to block a human sperm cell, which means it technically prevents pregnancy.
But not small enough for viruses.
Not even close.
Hmm.
Those same pores are absolutely massive compared to a virus. Pathogens like HIV and hepatitis B pass right through lamb cecum without any resistance.
Wow.
Yeah. Latex or polyurethane condoms, on the other hand, are solid synthetic barriers and do not have these pores. That is such a critical distinction for you listening. It's not just about family planning. It is about baseline disease transmission. The marketing of natural absolutely does not equate to protected.
Not in this context, no.
And speaking of things that sound protective but really aren't, let's look at spermicide, specifically nonoxynol 9 or N9.
Right, N9 is very common.
Logic would tell you that adding a chemical designed to explicitly destroy sperm would be a massive net positive for a barrier. But the source points out that frequent use of N9 can actually increase the risk of HIV transmission. How is that possible?
This comes down to the mechanism of how the chemical operates. N9 is a surfactant,
A surfactant.
like soap.
Exactly like dish soap.
Yeah.
Just as dish soap breaks apart the chemical bonds of grease on a frying pan, N9 aggressively breaks apart the lipid layer, the fatty outer cell membrane of the sperm cell, neutralizing it.
Sounds effective so far.
It is, but the chemical cannot differentiate between a sperm cell and the cells lining the human body.
Oh, I see where this is going. Yeah. If used frequently, which is clinically defined as more than twice a day, that same harsh, soap-like action strips the natural barriers of the vaginal or rectal lining. It causes severe irritation and creates microscopic lesions.
So it's literally creating open wounds.
Microscopic ones, yes. And those tiny abrasions provide a direct, open doorway for viruses like HIV to enter the bloodstream.
Okay, so all of this, taking your temperature before you even move, analyzing the stretchiness of cervical mucus, making sure you're using latex instead of lambskin, avoiding harsh surfactants, it relies entirely on the user performing a sequence of events perfectly, every single time.
Which brings us right back to the human error problem.
Exactly. To eliminate that daily human error, modern medicine developed hormonal methods and long-acting reversible contraceptives, or LARCs. And here's where it gets really interesting.
The hormonal shift changed everything.
It did. With combined oral contraceptives, the standard birth control pill, you are taking a daily dose of synthetic estrogen and progestin. This tricks your body's endocrine system, specifically suppressing the hypothalamus and the pituitary gland.
Which stops them from sending the signal to your ovaries to release an egg.
I like to think of it like this. Taking the daily pill is like calling a factory every single morning to tell the manager to halt production.
I like that analogy. The daily phone call keeps the assembly line shut down.
But if you forget to make that call,
Then the factory manager assumes everything is back to normal, powers up the machines, and ships out the product. In this case, an egg.
and that reliance on the daily phone call is why the pill has a typical failure rate of about 7%.
Right. It is almost entirely due to omitted doses. People simply forget to call the factory.
And there are physiological side effects to consider, too. Providers teach patients the ACS warning signs. That's ACHES, abdominal pain, chest pain, headaches, eye problems, and severe leg pain.
Those aren't just random symptoms to watch out for. They are indicators of rare but severe cardiovascular events.
Because of the estrogen.
Exactly. The synthetic estrogen in combined pills is metabolized by the liver, which responds by slightly increasing the production of blood clotting factors.
Okay.
For most people, this is harmless. But for some, it can lead to a deep vein thrombosis, a clot in the leg causing that severe pain, or even a pulmonary embolism if the clot travels to the lungs, causing chest pain.
Because of those estrogen risks, the medical field created progestin-only options, like the mini pill. But that requires you to take it at the exact same hour every day.
Even less room for human error.
Right. Or injectables like Depo-Provera, which you get every 3 months. But even Depo comes with a biological trade-off, according to the text. It suppresses estrogen so much that it can impact how bones absorb calcium.
Yeah, it actually carries a warning for potential loss of bone mineral density over time.
Every intervention has a biological cost. Which brings us back to the factory analogy and why long-acting reversible contraceptives, or LARCs, revolutionized this field.
They really did, because an IUD or a subdermal implant isn't a daily phone call to the manager.
It's like replacing the factory's entire operating system.
Yeah.
You install it, lock the doors, and it runs on autopilot for years.
And by doing that, LARCs completely change the math we talked about earlier. With an implant like Nexplanon, which is a single tiny rod placed under the skin of your arm for 3 years, or an intracauterine device, theoretic effectiveness and typical effectiveness become exactly the same.
The human error variable drops to absolute zero once the device is in place.
Exactly. Now, intrauterine devices, or IUDs, fall into 2 distinct categories. You have the copper IUD, which lasts up to 10 years.
And that one has zero hormones, right?
Zero hormones. Instead, the copper ions continuously shed into the uterus, creating a highly localized inflammatory response.
So it's actually changing the physical environment.
Right. It summons white blood cells that make the uterine environment quite literally toxic to sperm, attacking and neutralizing them before they can reach the fallopian tubes.
That is intense. And the other option.
Then you have hormonal IUDs, which last 3 to 6 years depending on the brand. They release a tiny, steady dose of progestin directly into the uterus.
What does the progestin do locally?
It severely thickens the cervical mucus, creating an impenetrable plug while also thinning the uterine lining so an egg cannot attach. The typical failure rate of a hormonal IUD is a microscopic 0.1%.
It really is an engineering marvel.
Ah.
But of course, no system is entirely foolproof. What happens when the primary method fails? The condom breaks, the pill is forgotten, the factory starts production.
We move to the backup plan, emergency contraception, or EC.
Usually referred to as the morning after pill.
Right, but the clinical window is actually much wider than the morning after. A patient has up to 120 hours, so 5 days to use it, though efficacy does decrease as time passes.
And how does it actually stop the process?
Oral EC works primarily by delaying ovulation. It forces the factory to pause just long enough for any sperm currently in the reproductive tract to die off.
But if the egg is already released,
Crucially, if ovulation has already occurred and an egg has been fertilized and implanted, these medications will not disrupt an established pregnancy.
okay, I think a lot of people assume a pill is just a pill, and a standard dose works exactly the same for everyone. But there's a massive revelation in the textbook regarding emergency contraception.
Yes, the weight variable.
Clinical data shows that obesity and being overweight significantly negatively affect the efficacy of the oral morning after pill.
I mean, why does a person's weight change how this specific medication works?
It is a matter of pharmacokinetics, which is just the study of how a drug physically moves through and is absorbed by the body.
Okay.
Hormonal medications are lipophilic. That means they are naturally drawn to and dissolve into fat tissue.
So they seek out fat.
Yes. When an individual has a higher body mass index, they have more adipose or fat tissue. That tissue acts like a giant sponge. Oh, I see.
When they take the standard dose of oral EC, the hormone gets absorbed and dispersed across a much larger volume of this sponge.
So it's basically soaking up the medicine before it can reach the target.
Exactly. Consequently, the concentration of the hormone left circulating in the bloodstream simply isn't high enough to reach the ovaries and successfully delay ovulation.
That is a massive aha moment for self-advocacy. If you don't know the biology of how your specific body composition interacts with lipophilic drugs, you might take an oral EC assuming you're fully protected when, biologically, the dose was entirely absorbed before it could even do its job.
Which is why the clinical standard dictates that for obese individuals, the absolute most effective emergency contraception is actually the insertion of a copper IUD.
Because it's a localized environment change.
Precisely, because the copper acts locally inside the uterus to create that hostile environment for sperm, it does not have to travel through the bloodstream. It entirely bypasses the metabolic variable of body weight.
That proves that medical care can never be one size fits all. So we've covered the preventative side. What does this all mean when contraception isn't used, or when it fails, and an unintended pregnancy does occur?
The source text does cover the clinical landscape of induced abortion, which is undeniably complex.
Right, and just to be completely clear for you listening, we are not taking any political sides here. There are deeply held beliefs on all sides of this issue. We are strictly reporting the medical and legal facts exactly as they are laid out in the source text, so you have the information.
And looking at it through a factual medical lens, the clinical reality simply cannot be separated from the legal context right now.
No, it can't. Not anymore.
In June 2022, the United States Supreme Court overturned Roe v. Wade in the Dobbs decision. What was previously a federally protected right instantly transformed into a state-by-state patchwork of conflicting laws, trigger bans, and severe restrictions.
So the medical procedures remain exactly the same, but a patient's access to them is now dictated almost entirely by their geographic zip code.
That is the current reality, yes.
Medically speaking, the source notes that 90% of all these procedures occur in the first trimester. And there are two primary mechanisms.
Right. The first is aspiration, sometimes called suction curettage. This is a brief outpatient surgical procedure that uses gentle suction to evacuate the contents of the uterus.
Yeah, and the second method.
The second is medical abortion, which accounts for a significant and growing portion of early procedures. This is a highly specific two-drug regimen.
How does that work biologically?
First, the patient takes mifepristone. This drug acts by actively blocking the body's progesterone receptors. Now, progesterone is the hormone absolutely required to maintain the uterine lining and sustain a pregnancy.
So without it, the environment shuts down.
Exactly. Without it, the pregnancy stops growing. Then, 24 to 48 hours later, the patient takes misoprostol, which stimulates the uterus to contract and expel the tissue.
What about later procedures?
For second trimester procedures, which are statistically much rarer, the primary clinical method is dilation and evacuation, or D&E.
And the text places a huge emphasis on the nursing care following any of these procedures. It remains highly standardized across the board.
Very standardized. Clinicians are monitoring for very specific physical complications.
Right, the warning signs are precise. They are looking for a fever spiking over 100.4 degrees or heavy hemorrhaging, which is clinically defined as soaking through more than 2 sanitary pads in 2 hours.
Those are the physical markers, yes. But beyond monitoring vital signs, there is a profound ethical dimension to the care provided in this space.
Especially now. We have these highly specific medical protocols intersecting with a rapidly shifting, highly charged legal and political map.
And this raises an important question about the ethical duty of healthcare workers navigating this environment. The textbook is clear. Major nursing and medical associations are unequivocal on this point.
What's the mandate?
Regardless of a provider's personal, religious, or political views, they have a strict ethical responsibility to counsel patients impartially.
So they can't let their own views enter the clinic.
They cannot. They are mandated to provide unbiased, medically accurate information about all available options, to respect the patient's autonomy to make decisions based on their own personal values, and to rigorously guard against patient abandonment.
The fundamental goal is clinical safety and informed consent, isolated as much as possible from external judgment.
Exactly.
It really circles back to where we started this entire conversation, trying to find precision, care, and safety in a landscape that can be incredibly difficult to navigate. For you listening, we have covered massive ground today.
We really went from analog to digital to legal.
We did. We started with the deeply analog reality of moving beads on a string and tracking the physical stretch of cervical mucus. We explored the set it and forget it's engineering of subdermal implants and intrauterine devices, unpacked the biological reasons why body weight absorbs emergency pills, and looked at the intersection of medical protocols and shifting legal realities.
If we connect this to the bigger picture, reproductive health is profoundly complex precisely because it is profoundly human. It requires patients and providers to constantly negotiate the space between theoretic, perfect biology and the messy, typical reality of everyday life.
Absolutely. And as we close out today's deep dive, I want to leave you with a final lingering thought to mull over on your own. We talked earlier about those algorithms and apps DOT, natural cycles, and the wearables syncing to our phones.
The massive data sets.
Right. Millions of users are uploading their daily basal body temperatures, the exact consistency of their cervical mucus, and the dates of their menstrual cycles. As technology merges so intimately with our reproductive biology, who actually owns those billions of deeply personal data points?
It's a huge privacy concern.
And in our new post-Roe legal landscape, where state laws differ so drastically and legal jurisdictions are blurring, how might that intimate biological data be utilized, subpoenaed, or even monetized by third parties? It is a brave new world out there, and the murky waters of that diagnostic landscape are only getting deeper. Thanks for diving in with us.